Let's just wait a second till we have a full quorum here. Who is iPhone 629?
Sorry, that's me. I'm a referred.
Who is it? Who is that?
That's me. I'm a referred, the medical student on the
Oh, hi.
selective.
Okay, just want to make sure we don't have spies. Okay, why don't we get going? So this is a electrogram from somebody who has WPW, and the question is, where is the pathway located? So why don't we see what Dr. Mukhopadhyay thinks about this. Is it possible that I said Katoki's name improperly and she didn't know I asked her?
Good morning, Dr. Cass. I'm trying to figure out what the answer is. Sorry.
Okay, that's okay. So just for clarification, we have the 4 surface electrocardiogram leads, high RA, a single His channel, which is different than what we normally do during a case where we have 3, proximal coronary sinus, and distal. So this is also different. Normally we have 4 or 5 channels, and then right ventricle.
I think it's in the distal coronary sinus.
Okay, I agree with that. That is a solid second-year fellow answer from a first-year fellow. Good job. Now, how do you know that? Or so we're pointing. So if it's in the distal coronary sinus, where is the pathway located? On the right side or the left side of the heart?
It's on the left side.
Yep, right, because remember the mouth of the coronary sinus is in the posterior septal region of the right atrium. Distal coronary sinus would be out in the left lateral wall, sort of around the mitral annulus. Could even be anterior on the mitral annulus, lateral anterior. Okay, so how did you know that it was in the distal coronary sinus? Okay, you still there? Hello? Katoki, you still there?
Sorry, yeah. The earliest it seems the earliest QRS is in the, because you were circling that thing, so I thought the earliest QRS was there. That's why I thought it's probably.
So we wouldn't, when we're talking about an intracardiac tracing, we would say the earliest electrogram. It's not really the QRS, right? A QRS is these complexes on a surface ECG. So yes, the earliest ventricular electrogram is in the distal coronary sinus. So remember that when we're looking at tracings, it's always easiest to look at what you are used to looking at and then look down into the intracardiacs. So if we look at this beat here, it's clearly a P wave, clearly a QRS. So because all of the channels are simultaneous, we know that if there's a P wave in the surface electrocardiogram, then there ought to be an atrial electrogram on the internal, on the intracardiac tracing. So here we have high RA. There's an A in the His bundle, an A in the proximal CS, an A in the distal CS, and understandably no A in the right ventricle, right? Because we presumably are in the apex, far from the atrium. If we were recording RV from just inside the tricuspid annulus, you might see far field atrial electrogram, but typically you should be far enough into the ventricle that you don't actually see an atrial electrogram. So then when we look in the His, and then in the high RA, we see that there's this very little signal here that seems to be corresponding to the QRS. And this is a far field V. And we've talked about this in the past, but the most common location that the atrial catheter is placed is the right atrial appendage. And as we all know, the right atrial appendage, which sometimes pathologists say looks like Snoopy's nose, hangs over the right atrium and even can extend down to the right ventricle, or at least to the tricuspid annulus. And so when you are in the right atrial appendage deep, it's possible that you can record far field ventricular electrogram, which is why there's a very tiny little electrogram that is simultaneous with the QRS. So when we go down to the His channel, we see that there is, in fact, a large ventricular electrogram that is simultaneous with the QRS, and the little signal in between is the His electrogram. So A, H, and V. And then when we're in the coronary sinus, remember that the coronary sinus sits on the mitral annulus, and so we should be able to record both atrial and ventricular electrograms, because we should be relatively well balanced on the annulus between the atrium and the ventricle. And so we see here an A and a V, and then an A, and then this V seems to be starting quite a bit earlier than this V, which is unusual, right? Normally, if we're conducting from the atrium to the ventricle via the AV node and His-Purkinje system, the His-Purkinje system should have the earliest ventricular electrogram, and as we move farther and farther away from the His-Purkinje system, the ventricular electrogram should be later and later. But in fact, it's earlier in the distal coronary sinus. So this is distinctly abnormal, showing that there is excitation of the lateral wall of the left atria, of the left ventricle, far before even the right ventricle is depolarized. In other words, in better terms, the ventricle is pre-excited. It is excited earlier than it normally would be because of the presence of an accessory pathway. And because the ventricular electrogram is earliest in the area near to the distal coronary sinus, we know that the pathway needs to be at least relatively close to this location. And one could even imagine that this little high frequency signal that the arrow is pointing to is almost like a pathway potential, which some people describe when you're mapping ablating pathways. But the bottom line is that this ventricular electrogram should never precede the electrogram in the proximal coronary sinus, because the proximal coronary sinus is so much physically closer to the His bundle than the distal coronary sinus, unless, of course, the person is pre-excited. And the other thing that's noteworthy is we've talked last week that the normal H to V interval, Katoki, how long is the normal HV interval? I think Tulsi told us last week what the normal HV interval was. You remember?
Sorry, that was it's in the 50s.
Say that again.
50.
50. So yeah, well, it's 35 to 50 to 55 milliseconds is usually a normal HV interval. So, but when someone is pre-excited, the H to V interval is usually much less. It could even be negative. And this is a beautiful example of that. So here's the H, the inflection of the His. And if in your mind's eye, you were to draw a line straight down from here, I think you would agree that the ventricular electrogram is essentially starting on time with the His. It may even be, if you imagine that this is part of the ventricular electrogram, it may even be before the His. So if we were to measure the H to V interval, it would be basically zero, because the HV interval is officially the distance between the His and the earliest ventricular electrogram in any lead on the page. And so in this case, the earliest ventricular electrogram is in the distal coronary sinus, and the H-V interval is essentially 0. So that shows that there is, in fact, pre-excitation, in this case, pre-excitation of the lateral wall of the left ventricle as a result of the presence of a left-sided accessory pathway. Okay. Any other questions about this, Tracy? Nope. Okay, we'll move forward. All right. So this is ventricular tachycardia. And the question is, and this was from an online tracing I got a number of years ago from the Tehran Arrhythmia Center. Used to show this tracing when Joseph was a fellow. What is happening in the atrium? So just to orient everyone, we have 3. So again, I remind you that you always, when you're looking at an intracardiac, want to look at the legend on the left-hand side, because it changes from lab to lab and case to case. So even between Barry and I, we use a slightly different demonstration of the signals. So here we have 3 surface electrograms. ECG leads. We have 2 right atrial leads, distal and proximal. We have 2 His channels, a proximal and a distal, and we have a distal right ventricle. So I'm going to ask, Dr. Barris, who's joining us from the world of imaging, see what he thinks is going on in the atrium.
So it looks like we're getting decremental conduction, just because we're getting a V, and then it looks like a retrograde A on that first beat, and then you get a V, but then the A comes a little bit later on the second beat, and then maybe the third beat even later, and then it's no more A anymore. You have a dropped A, because it doesn't conduct anymore, and then it starts to conduct again on the next beat.
So what would we call this, David? What is this?
So it'll be Wenckebach, but it's decrementing at the AV node, but retrograde.
Right. So that's exactly right. Great answer, Dave. So this is an example of retrograde Wenckebach conduction. So remember that, of course, you can have antegrade Wenckebach conduction. We see that all the time in the cath lab and also in real life on Zio patches and Holters and Barty devices. But this is an example of how the AV node also conducts similarly retrograde. So in this patient who is having VT, there is in fact retrograde Wenckebach. So here, as David nicely pointed out, here's the V and here's the A. So we could, in your mind's eye, you could measure this VA interval. And then here's the next V. And then this A, I think we would agree that the interval between this V and this A is less than between this V and that A. And then, as Dave said, this V and this A, the VA interval is even longer. And then finally, there's a V and no A. And then the next V has a similar VA interval to this complex. And then in similar fashion, the VA interval is lengthening, and then we don't see what happens on the next beat. But so this is a very nice example of retrograde ventriculoatrial Wenckebach in the setting of VT, which we could also see this just with straight V pacing as well. Any questions? Okay, we'll move on. All right. So this is a patient who's having a ventricular stimulation study. And now usually we pace the ventricle during a V-stim study, just like we do atrial extrastimulus testing, where we pace the atrium for 8 beats and then put in a 9th beat at an earlier and earlier interval. In ventricular stimulation study, we do the same thing. But in this lab, rather than pace the V, all they do is just put in an S2 and an S3. So this is double ventricular extrastimulus testing in a patient who presumably needed a V-stim study. And so what we have here are 4 surface electrocardiograms, leads 1, 2, 3, and V1, a high RA channel, and then finally an RV channel. And so what is this arrhythmia, and what would you do for therapy both acutely and chronically. So why don't we ask Dr. Bezdakova what she thinks is going on here.
Hmm. Hello, Dr. Pass. So I think this arrhythmia looks like monomorphic ventricular tachycardia. And then in terms of therapy,
Well, let me stop you for a
Yeah.
moment. So you're saying, I agree with the statement that this is ventricular tachycardia. Is this monomorphic though? I mean,
no,
monomorphic
yeah.
means single morphology, right?
yeah, so it's more polymorphic.
Right. So this is like polymorphic, and when it gets like this way, where it's like so fast, and you could basically say this maybe it starts out as polymorphic VT, it becomes almost like VF sort of at the end, or slow VT. But okay, so you've induced a pretty bad ventricular arrhythmia. By the way, do you see any relationship between the ventricle and the atrium?
It looks like the atria has a pretty regular
Right. So they're
heart
pretty
time
much
interval.
dissociated, right? The
Yeah,
ventricular
yeah.
rate is like 3 times the rate of the atrium. And you can almost imagine that the atrium is kind of in some kind of sinus rhythm, or while the ventricular rate is all over the place. So the last patient we showed VA conduction, albeit with Wenckebach. This is an example where, well, of course, nobody's AV node can go this fast, retrograde or antegrade. So there's VA dissociation. Okay, so how would you, so this happens during a case. How would you acutely manage this?
So you can please correct me if I'm wrong.
I surely will.
Which I might be. So if you're in a case, I mean, this looks like it's I don't know if you would say non-sustained. So
Well,
and
no, it's not
you're
non-sustained, right? I mean, the page ends here and we're still in
yeah.
it. So, I mean, it's
Oh, yes.
possible it stopped a second later, and we would hope it would stop, but
Would you ablate this pathway
well, no, my first
managing?
question is, what are you going to do right now? So this patient is in this rhythm. What do you think's going on with the blood pressure in this rhythm?
It's the blood pressure. The patient's probably hemodynamically unstable.
That's right. The blood pressure is probably close to 0 right now. So what are you going to do to get this patient, to help this patient?
So you would need to defibrillate this patient?
Right. You'd need to defibrillate this patient. How many joules per kilo would you give this patient? Let's say it's a 50-kilo 10-year-old.
So you would start at 2 joules per kilo?
Right,
So,
exactly right. Very important. Ventricular arrhythmias, we always start at 2 joules per kilo. So give 100 joules, and you would give it asynchronously, right? Because you're in sort of basically you're in VF at the end here. So this it's not possible. The problem if you try to synchronize to this is that it may not be able to sense the R wave very well, and it may not deliver the energy. And then what can sometimes happen if you set it as synchronized is you're trying to set it, the devices, you turn it on, you press to defibrillate, it's looking for an R wave so that it can confidently know that it's putting the shock not on a susceptible portion of the T wave. And it doesn't deliver because it can't see the R wave. And then the classic disaster is when someone goes over to the patient and tries to figure out if the pads are on properly or whatever. And as soon as they're touching the patient, whammo, the device defibrillates both the patient and the medical care provider. So you would do this asynchronously. Now, let's say you gave 2 per kilo and it failed. What would you then do?
Then you increase to 4 per kilo.
Right. Then you'd give 4 per kilo, and you would have somebody drawing up amiodarone or lidocaine or both, or procainamide, because you would start initiating PALS basically. Okay, now I'm just going to tell you for the sake of discussion here, that having a reaction to two extra stimuli. So this would be called ventricular double extra stimuli. Now, we don't know how early these are because this is a shitty tracing with no lines and no numbers. So I apologize for that. This is from some old book that my friend handed to me as a gift as he was retiring. But I guess Ehud Krongrad was his name. But the question is, or the point I'm trying to make is double ventricular extra stimulus testing should not in normal patients induce this arrhythmia. This would be considered in almost anybody an abnormal response to stimulation. Now, sometimes when we're doing a ventricular, so in a ventricular stimulation study, we do single extra stimuli, we then do double extra stimuli, and then we do triple extra stimuli. And sometimes when we're giving 3 extra stimuli, and they are very, very premature, for example, let's say 200, 200, 200, meaning 200 milliseconds between each of the extra stimuli. That is a very aggressive form of stimulation, and a small percentage of healthy, normal patients will have this type of response to triple extra stimuli that early. And so sometimes we don't know what to do when we get this type of a response to extremely aggressive ventricular stimulation. In those cases, the specificity of the study is hurt by the degree of aggression that we used, which is why we try not to get too aggressive in VSTEM studies, because the specificity of the study becomes less value. But in this case, when we see this type of reaction to double extra stimuli, we would be generally pretty nervous about this patient, because most patients, even those who have bad arrhythmia conditions, will not do this in response to double extra stimulus testing. So this is this is all a long way of saying this is a very positive study for inducibility of VT or VF or potential risk for this happening spontaneously in this patient in the future. So, okay, so you've now induced this, you have given your 2 joules per kilo, the patient converts to sinus, everybody in the room feels a lot more comfortable now that the patient is no longer acutely dying, the blood pressure has immediately come back, patient is fine. So now that you've had this reaction to this test, which you're glad you did because it was grossly positive, what are you going to recommend, Christina, for this patient? Or what could you recommend? Or there's no exact right answer, but what would be some of the things you would think about?
I think since we're in the case right now with the patient, then I recommend ablating that pathway that is causing this.
Well, I mean, interestingly enough, this type of arrhythmia, usually there is nothing to ablate. Now, that's a very blanket statement. In the world of adult cardiology, people who have had heart attacks and have scar in their ventricle, there are types of VT like this that are ablatable, but in children in general, or I should say in anybody, even if we felt that this was ablatable in some way, we would never, with such a profoundly dangerous arrhythmia, we would never actually trust that the ablation would be adequate to protect the patient. We would be hopeful that the ablation would make this less likely, but we never, ever, when we're dealing with this type of a profoundly dangerous arrhythmia, we would never feel comfortable alone that the ablation was adequate.
I see. So then maybe in the interim, should start the patient on a beta blocker, and then also put in an AICD in case this ever happens while the patient is out in the world.
Yes, so we would almost always, in somebody like this, strongly consider implantation of an ICD. Even if we felt that there was something we could ablate, and even if we then went on to do a 6-hour ablation and felt reasonably confident that we ablated it, this comes up, for example, in tetralogy of Fallot. So as you probably know, and as we've discussed, there are actually areas in the right ventricle that are typically involved in the VT that is seen in these patients. And these areas can be ablated. These are called isthmuses for VT, and they can be ablated, and with some efficacy, can really reduce the incidence of VT quite significantly, maybe even make it zero. But when you see this type of arrhythmia, or even something less worrisome, you'd have to feel very confident. The patient would have to have an arrhythmia that is extremely well tolerated hemodynamically to consider not placing an ICD in such a patient. And I'm not suggesting that we wouldn't consider ablating certain types of ventricular arrhythmias, but we would never use that as a single therapy for such a patient. So we would do the ablation if there was one to ablate, and then we would proceed with implantation of an ICD. So in a case like this, where we were worried that we might induce this type of arrhythmia, you would typically get consent for a ventricular stimulation study, but you would also get consent for implantation of an ICD in the event that the VSTIM study was positive. And in terms of medication, there is really no right answer. A beta blocker is not unreasonable. I don't think there's very much evidence that beta blockers are very beneficial in this type of circumstance, although in the adult world, beta blockers do reduce all-cause mortality in people who have various forms of coronary artery disease. But the bottom line is it's not unreasonable to consider a beta blocker in this patient. This might need something more. Normally in pediatrics, we would put a device in a person like this, and we would, if they're not having episodes, we would, I always say I give patients one opportunity to die, meaning that we would just leave the device in and see how they do. Interestingly and thankfully, most pediatric patients who are at risk for sudden death, their devices do not go off with great regularity. That's a general statement. Obviously, there are patients with very bad arrhythmias, but in comparison with the adult world, our patients don't use their ICDs as often. And so most times I will allow patients put the device in and see how they do before we consider putting them on medicine. Now, if a person had, say, a long QT syndrome where we know that beta blockers reduce the incidence of arrhythmia, of course, we would put the person on beta blockers as well. Because as many of you have heard me say to patients with ICDs, what we really want is that the device never goes off. We just like to know it's there in case there's a problem. Okay, very good. Beat this question to death. All righty, so we are pacing this patient at cycle length 530, which I would remind you, we divide 60,000 by the cycle length. So this is a rate of maybe about 110 beats per minute. And someone has been kind enough to measure something in milliseconds. So we have 4 ECG leads, a high RA, and a His bundle electrogram, just a single His bundle electrogram. So I'm going to ask Dr. Kalis for her thoughts on what's going on here.
All right. Good morning. So I see, so it looks like on the bottom tracing, on the His tracing, they're giving us what looks like the HV interval.
Yes.
And the HV interval is slowly increasing from 130, 145, 165, and then it looks like we have a dropped beat. So that looks like a Wenckebach phenomenon.
It is, but when we're doing Holters or looking at people on telemetry and we see that they're Wenckebaching at night, where is the Wenckebach usually occurring, Maya? I agree 100%. This is Wenckebach, but where does Wenckebach, like we've talked many times, and we don't like we don't mind.
I guess.
Right. And what does the AH represent versus the HV again?
So the AH is the signal, I guess, going from the atria to the ventricles, and then the HV is from like the from the from the AV node to the Purkinje system.
Right. So again, just so to just sort of, that's correct, but let me just restate it for you if it's okay.
Mhm.
We can't actually record the AV node on standard electrocardiograms from EP studies, but the A to H interval is inferred to represent AV nodal conduction from the atrium to the His bundle, and then the His Purkinje system conduction is the H to V interval. So normally when people are wenky-bocking, they are wenky-bocking in the AV node. So we typically see that this, as you aptly pointed out, this is progressive prolongation in the H to V interval, which is in fact wenky-bocking and then blocks. But normally AV wenky-bock is in the AV node. And it's because it's normally in the AV node, generally that is a benign finding, but this would not be considered a normal finding to see this type of His Purkinje disease. Also, one should be able to conduct, right, at a rate of 110 through your AV node His Purkinje system. So this is distinctly abnormal. And if we saw this, for example, in a postoperative patient, for example, we had a patient not long ago who had late conduction problems, and then it resolved. And so, the question was, should we put a pacemaker in? Should we not put a pacemaker in? Well, in that case, we elected to not place a pacemaker based on the fact that we then had another 2 weeks of observation of no dropped beats. But if one were really nervous about it, one could do an EP study such as this one. And if we observed this type of finding, where we're seeing HV prolongation followed by drop of the AV node of the QRS from HV block, that would probably be a worrisome finding and would warrant placement of a pacemaker. Now, we have seen in that patient that there was 100% conduction at all heart rates, at heart rates much faster than cycle length 530. So we feel reasonably confident that the patient is safe like this. But if you have a patient who you're really on the fence about, this would not be an unreasonable way to check it. And again, as we've discussed many times, when patients have heart block following open heart surgery, it's usually an injury to the His Purkinje system. And because that is a deeper or lower level of block, we are more concerned about such patients. They are at higher risk for Stokes-Adams attacks and sudden cardiac death following open heart surgery. So that's the reason we would be more concerned and put pacemakers in patients like this. Okay, any questions? I think if not, we're going to stop here. I hope everyone has a great day. And one other thing I wanted to mention, again, remind everybody, Dr. Daphne Sue from Montefiore is giving grand rounds on Thursday. So please try very hard to go to her talk in person, which is going to be in the usual grand rounds area. And then she has agreed to just sit and chit chat with the fellows about your lives and careers from 9 a.m. to 10 a.m. And we're trying hard to clear everybody of their clinical duties for that 1 hour. She's a great source of information and, a good advisor. And she actually asked me if she could have the opportunity to speak with all of you. So she's going to do that on Thursday. And Jackie and I have requested from everybody that they clear out, everybody manage the service without the fellows for that hour. Okay, guys, have a great day.
Thank you. Thank you.
Take care.
Thanks, Dr.
Bye-bye.
Bye.
Thank you.